I first got bitten by the bug of CM when I met Dr. Steve Higgins, who might arguably be the grandfather of CM for stimulant use disorder. And that was during my postdoc. And really what struck me is the seemingly simple approach that can have a really big impact on a really complicated problem, right? And I've been doing it ever since. So really glad to be here. My goal for today is kind of just to walk you through some of the drivers and the structure and the expectations for our CM pilot program here in Connecticut, which we are gearing up to launch. Next, please. So I'm going to start by just grounding us in the Connecticut situation. So in Connecticut, as is the case nationally, it is fentanyl that is driving harms on the opioid side of the equation. And in Connecticut, it's cocaine that's driving harms on the stimulant side of the equation. So for example, in 2024, 69% of opioid-involved deaths involved cocaine. There are a lot of deaths that are also involving cocaine that don't involve any opioids at all. And unfortunately, those rates are trending upwards recently. We're also seeing disparities along what will be familiar fault lines to many. So for example, non-Hispanic Black residents and males are disproportionately impacted by these harms. And we're seeing rising rates among older adults. Next, please. So with those harms in mind and potentially opioid settlement funds in hand, about a year ago, the Connecticut Department of Mental Health and Addiction Services approached me. And they said, would you by any chance possibly be interested in working with us to stand up a CM pilot program in Connecticut? And I have to say, it probably took me about 2 seconds to say, count me in. I was ecstatic. So their vision was to stand up CM services in 5 adult outpatient substance use treatment programs, 1 in each of the 5 health services regions in Connecticut, with the goal of serving at least 50 clients with stimulant use disorder per year per site over the course of a 2-year program, and to use CM to target stimulant abstinence because we know that that is the most direct way to reduce harms with contingency management. Days later, I think, we were at the Opioid Settlement Advisory Committee pitching this idea. Fast forward through layers of approval, RFP development, scoring all the proposals that we got in response. And here we are about a year later, ready to launch on this journey. Next, please. So with that in mind, I'm just going to go over a little bit about the structure of our program. So our guiding principle in putting this together was high fidelity, evidence-based CM. At the heart of CM is the incentive structure. So for us is 12 weeks of CM with twice weekly drug tests, incentives based on stimulant-free drug test results up to $5.99 per client. That incentive, those incentives, everything about them, the distribution, the monitoring, the fidelity, important guardrails that are all in place, those are all hardwired through the technology that we're using to manage all that. It is CMI's incentive manager technology. And even though we have that technology on board, we are keeping a human in the loop. And here's why. It was referenced earlier by Dr. Fries, I believe. Those one-on-one conversations with folks, the job really is to celebrate wins, big and small, and help folks engage with the CM program so that they're more likely to achieve their recovery goals. And that is really an essential part of what is evidence-based CM. Next, please. So it takes a village, as they say, right? So we have the Department of Mental Health and Addiction Services connected to an academic partner. That's UConn Health, i.e. me and my team. We have CMI as the technology partner, and we have the clinical sites. On the right-hand side, you see a little bit about how we're thinking about infrastructure and oversight. So we very intentionally are building on the strengths of those initiatives that are further along down this road than us. The California model is the gold standard as far as I'm concerned. We also are very intentionally building in features that address lessons learned. And you see kind of some of that played out here. So for example, all sites are required and get a budget for one new full-time hire that will serve the role as the CM coordinator. That person is going to work with a case manager and with a supervisor. And that 3-person CM team, they are boots on the ground at every site. We are using the CM technology to handle all the things related to incentives. Myself and my team will be providing the training and technical assistance around all things that are not the technology, and sometimes in partnership with CMI when that makes sense to do that. Throughout the program, we're going to have ongoing support through a variety of channels because we know that that is really critical to keeping things on the rails. Next slide, please. So with that structure in mind, I thought I'd just lay out a little bit of what we're thinking about in terms of outcomes. We have outcomes across 6 domains. They really fall into implementation type outcomes, so readiness, reach, fidelity, and then we have service outcomes. So your clinical outcomes like the drug test results, your treatment engagement and treatment and retention. And we're going to be closely monitoring equity. And the way we're going to be doing that is making sure that at a minimum, outcomes are disaggregated by race, ethnicity, sex, and by geography. Next slide, please. So those outcomes are great. They're going to give us great program, service level data, but arguably a bigger question here, given the context, is how do we connect the dots between those outcomes and relevance to overdose and related harms? And so I appreciate that this slide is very text heavy, but it actually serves my purpose pretty well, even if that involves a little Monday morning quarterbacking. And that is to say that the one take home is that there are options for connecting these dots that are reasonably feasible, even if you're standing up a relatively small, which might be everything compared to California, project. So some of these options are more straightforward than others because they are directly connected to the things that we are measuring. Things like sustained abstinence and retention and treatment. We already know that those are strongly linked to improved outcomes longer term. Others of these options involve things like leveraging external databases for comparison purposes. Others involve some statistical modeling. We are in very early days. As I mentioned, we're about to launch. We're already thinking about these things. I think it's really important to do so early on because they have upstream and downstream consequences. And some of them also take time. So things like leveraging external databases. So you want to be thinking about it early on so that everything's all set, neat and tidy when you're ready to press go on looking at these things. Next slide, please. And with that, I hope I've given you a taste of what our program, looks and feels like. If you have any questions afterwards, because sometimes hindsight is 20/20, or if you want an ongoing conversation, all conversations are welcome. Please, please, please reach out. And I really hope that this has been helpful. I'll hand it back to you, Larry.
All right. Well, Sheila, well, thank you very much. I really enjoy your approach on this, and it's so professional and insightful. 3 takeaways that I have from your presentation, Sheila, is number 1, your focus on program roles, responsibilities, and accountability. You're setting yourself up for success, and you've done so much planning and organization in this area. It's really impressive. Number 2, it'd be remiss for me not to point out that you're using some technology, some great technology, by the way. No, just and number 3, your real focus on outcomes. And that's what it's all about. Is you're looking to save lives, change the community, and that's so apparent in those last couple of slides. So, Sheila, thank you very much. I really do appreciate your contribution and wishing you the best.
Thank you, Larry.